Well, hello everyone. Thank you so much for joining us for our webinar, Bladder Cancer Basics, Essential Knowledge for Patients and Caregivers. I'm Teresa Blondin, the National Volunteer and Program Manager here at Bladder Cancer Canada, and I'm honored to be facilitating this session tonight. Bladder cancer is the fifth most common cancer in Canada, but many people aren't aware of it or its signs and symptoms until they're directly affected by it. Tonight, our goal is to raise more awareness, share vital information, and empower our community with knowledge. So before we dive in, just a bit of housekeeping. Your mics and cameras will remain off for the duration of this session. However, we'd love to know who's here with us today. So if you're willing, please drop your name and location in the chat. And please remember that webinars contain content intended for the sole purpose of information sharing and should not be considered medical advice. Always talk to your doctor and/or urologist about what is best for you. And if you run into any issues, myself and my colleague Mary Lou Cameron are monitoring the chat and happy to help. So now I'm honored to introduce our presenter for the evening, Dr. Paul Toren, who is a urologist at CHU of Quebec, Université Laval, an associate professor at the Faculty of Medicine at Université Laval, and a researcher at the Research Center of CHU of Quebec, Université Laval. Dr. Toren has a subspecialized interest in the surgical management of genitourinary malignancies, including prostate, bladder, and kidney tumors. He performs open surgery on complex tumors as well as minimally invasive laparoscopic and robotic surgery. Dr. Toren has worked as a clinician scientist in the Department of Surgery at Laval University, where his laboratory focuses on translational prostate cancer research. Thank you so much for being here again, Dr. Toren, and I will pass it over to you.
Great. Thank you very much, Teresa. And good evening, everyone. And thank you to the organizers of Bladder Cancer Canada. Tonight, as indicated, I'm going to do an overview of bladder cancer. It's not certainly going to cover everything, but hopefully will inform you more and also permit the time at the end for questions, informational questions, of course. So with that, I'm just going to try and share my slides here in a second. Great. Now I hope you can see that. And so as Teresa indicated, I'm a urologist in Quebec City, and I'll be talking to you about bladder cancer. I do have some conflict of interest. I'm a researcher, and so I'm involved with support from various companies as well, including AstraZeneca, as well as government support from the Canadian Institute of Health Research and philanthropic support from the Cancer Research Society. And some of that we'll touch on briefly at the end. And so the objectives of today is what is bladder cancer, overview of statistics, symptoms, different types of bladder cancer, some explanation of grading and staging. We'll go through some of the treatments, not exhaustively, and then we'll also mention some of the ones in development. So right into it, what is bladder cancer? Well, bladder cancer cells. The bladder has different types of cells, and essentially there's cells called urothelial cells. It's essentially the lining of the bladder. And it's not only the lining of the bladder, but also the kidneys and the ureters, which are the tubes draining the kidneys. And those cells transform, become different in such a way that they proliferate or they grow faster and they multiply. And that's one of the defining characteristics of cancer, is that it grows faster than it should in an uncontrolled way. And that can happen with these cells, which normally do grow fast, normally replace fast, but when they become transformed and cancerous, then it causes problems. So just to start off with a few facts, bladder cancer is the fifth most common cancer in Canada. It affects over 80,000 Canadians. They calculated 37 people a day are diagnosed, 13,000 a year. Most people, not everyone, but most people present with blood in the urine. And this is why being aware of this isn't something abnormal and seeking physician medical investigations is important to not delay things. It is very expensive to treat, and one of the reasons for that is that it's a good reason in the sense that a lot of patients are cured and do well and are followed for a long time, because there is a tendency of bladder cancer to recur and to come back. And this, of course, incurs costs over the long term, which are important. We'll talk about non-muscle invasive bladder cancer, and it does have a high recurrence rate, 60 to 70% in some studies. The biggest risk factor we'll get into is smoking. And overall, there's a good survival rate at 77%, but it depends a lot. And so that's not the most useful statistic in my view, but that's it. So what are the risk factors for bladder cancer? The two big risk factors, the ones that are the most predominant and influence the results the most, are actually your sex. Male patients have much higher risk of bladder cancer than female patients, and smoking. People who smoke, who've been lifelong smokers, exposure to smoke a lot, have a higher risk of bladder cancer. And that's a risk factor which is modifiable and which is important because improvements in that can actually improve the outcome of individual patients by stopping smoking. There are other risk factors well described. Briefly, anything that chronically irritates the bladder. There's something called schistosomiasis, very prevalent in Africa, not really in Canada, but that chronic irritation with a catheter in the bladder over decades can certainly cause cancer in some patients. There are chemotherapy agents used for certain cancers, not that commonly, which, as a result of passing through the bladder and essentially irritating the bladder, can cause cancer years later. There are certain genetic factors as well, certain genetic syndromes, which on the whole are rare, but there are some known to relate to bladder cancer. And there are industrial exposures. Patients who worked in certain types of factories producing dyes and um, potent chemicals in aluminum factories and things like that can induce bladder cancer. And so that's another occupational exposure, which is better than it was in decades past, but is still an issue. So what are the symptoms? I think Bladder Cancer Canada has done an excellent job in this awareness campaign, because blood in the urine is not normal, and that is the most common symptom. There are other symptoms which are not specific. So people who have to pee a lot have trouble with an urge to urinate more. Certainly not all of them are bladder cancer, and most of them, in fact, are not, but these are symptoms that can be an indicator of bladder cancer. And they're listed there for you. And pain can be, of course, a cancer symptom, whether it's pain in the bones from the metastases or pain in the region of the pelvis, of course, depending on if the cancer is more advanced or not. And so there are general things like weight loss, swelling in the feet, bone pain, lymph nodes which are swollen, and so on. But these are symptoms of advanced disease generally. So a question that comes up a lot in clinic is there something that can prevent this? And so modifiable risk factors are important in that regard. So avoiding exposure to smoking, avoiding exposure to dangerous chemicals. These are things that can prevent getting a bladder cancer. On the whole, my recommendations to my patients are to eat well and exercise. Why? Because it's your mother's good advice, but also because it's true. These things are helpful to decrease your risk of cancer, among other things. And so alcohol moderation is important. Stopping smoking, if you smoke, is certainly helpful. And so these are mostly common sense advice, but it's helpful to be reminded of these things. So how is bladder cancer diagnosed? Well, as a urologist, we have a tool we call a cystoscope, which is essentially a catheter that we pass by the natural passageways, and we look inside the bladder, and we can see if there is a tumor or not visually, and that's how the diagnosis is first made. It can be also seen on imaging scans, but they're not necessarily they're not as sensitive as visual inspection, but certainly CT scans and ultrasounds can be helpful. Ultimately, the diagnosis pathologically, that is, the confirmation that it's cancer, is done when we remove a piece of the tumor, and that's usually done by what we call transurethral resection of a bladder tumor, or TURBT. And so looking at the different types of bladder cancer, and they are different. Someone who has what we call a non-muscle invasive bladder cancer has cancer that remains superficial. So it's something that hasn't invaded the different layers of the bladder, or hasn't invaded the deeper layers of the bladder. That is the deeper layer of the muscle. The muscle is what contracts your bladder and what makes it squeeze. And when the cancer's invaded the muscle or muscle invasive bladder cancer, that's something that has a much higher risk of spreading elsewhere. And so that's treated differently according to that risk. Advanced or metastatic bladder cancer are more or less interchangeable terms that we use to describe a cancer which has started in the bladder but has spread elsewhere, either in lymph nodes or in the bones or in other organs. And that's treated differently than the first two. The fourth grouping of bladder cancer, or what is called in pathology urothelial carcinoma, is in the upper tract. The upper tract refers to the urinary system in the kidneys because the kidneys produce urine, and then it goes down your eaves troughs, as it will, through these tubes, the ureters, into the bladder. And anything that's above the bladder, either in the ureters or in the kidney, renal pelvis, is referred to as upper tract urothelial carcinoma. So how do we stage? So staging and grading are not the same thing. Staging refers to what extent has the cancer gone to? And this could be the extent, is it localized or is it metastatic? That is a type of staging. Staging also refers to locally, is the tumor, and we referred to this already, is the tumor something that invades the bladder or is it something that is just superficial? And the scale is in front of you there. TIS, or also more commonly referred to as CIS, which means carcinoma in situ, means that it's something that's in the layer of the first layer, but not invading anything. So it's flat. It's a flat, unique cancer. It has a bit of different characteristics. And then you have TA, which is something that's in the first layer, the urothelial cells, but not invading anything below it. And that's very good because it's not invading anything. T1 tumors have already invaded the first layer, which we call the lamina propria, but have not invaded the muscle. And so they are considered non-muscle invasive bladder cancer, as referred to T2 or T3, is invaded the wall, the meat of the bladder wall, the muscle there, and then it goes into the fat, and that's invasion T3. So grading is something different. Grading refers to under the microscope, when the pathologist looks at the tumor, we take it out, it gets cut up in we call sections and put on some slides and examined under a microscope. Under a microscope, things can look like they're rapidly dividing, or things can look like they're not rapidly dividing. And more rapidly dividing, the more aggressive the cancer is. And so that's considered high grade. And then low grade is less invasive. So it's called low grade. There is something called pun lump, which is even better than low grade in the sense that it's barely a cancer in a sense, or not necessarily considered a cancer, depending on who you ask. So that is the grading, and that's important because again, that dictates what the treatment will be, because something that's less aggressive, that doesn't grow very quickly, doesn't necessarily need the same treatment. And so treatment depends on the grade and stage, and obviously this has to be according to the patient, whether it's localized or spread elsewhere. This is a list, not exhaustive, of the different treatments. So the first is the diagnostic procedure, the surgery that we remove the tumor, and we find out what it is, but we also remove it, so it's gone. And that's what we call a TURBT or TURBT. There are treatments that we give in the bladder to reduce the recurrence rate, as we sort of mentioned quickly. Bladder tumors that are non-muscle invasive certainly have a tendency to come back again, unfortunately. And so we give treatments that prevent recurrences, and that's in the form of BCG, which we'll talk about, which is a tumor vaccine, if you will, and we call intravesical chemotherapy, or chemotherapy that we put directly by a catheter into the bladder. There are more radical treatments for more muscle invasive disease, and that includes combination of chemotherapy, radiation, and removal of the bladder entirely to get it all out and remove the tumor before it spreads elsewhere. And that's obviously a radical treatment. There are systemic treatments. Obviously, if the tumor has gone elsewhere, then removing the bladder is not of much benefit in almost all circumstances. But we do have many systemic treatments now, which are effective. This comes in the form of immunotherapy, chemotherapy, and targeted therapy. We'll talk about this. And of course, clinical trials are really part of the treatment options, and they often can be good treatment options because this is how new treatments get introduced and advance improve the outcomes for our patients. So TURBT, it's an outpatient surgical procedure. So most patients go home. Many go home with a catheter after, but not necessarily. And we use our instruments to go in, scrape out the tumor, and the pathologists look at it to tell us what is the grade and the stage. Like any surgery, there are risks of bleeding, infection. It's not uncommon to have burning and urgency for the days and sometimes for a week or two after. Things are healing up the inside. There's a scab forming in the inside of the bladder, and so this can irritate the bladder. Most patients are pretty well 3-4 weeks later. If all goes well, as I mentioned, catheter may be required, and there may be some symptoms after. It's done under general anesthesia, so you're not aware. BCG is a treatment that we use to prevent recurrences for non-muscle invasive bladder cancer. It's a type of immunotherapy in the sense that it stimulates your own immune system to attack and prevent the cancer cells from developing tumors. And there are side effects. The inflammation that it causes is helpful for the cancer, but it also causes urgency, burning, and these symptoms can pardon me, they can accumulate over time. And so we usually give this in a series of 6 treatments, once a week for 6 weeks. And then we'll give them often 3 weeks at a time, at 3 months, 6 months, and every 6 months after, up to a year or 3 years, depending on the situation. And often at the 5th or 6th treatment, the symptoms are more bothersome than they are right at the beginning, but many patients go through it without any symptoms as well. It's obviously variable. And so that's a treatment that's been around. It's actually been around for 50 years now and was invented by urologist Dr. Morales in Kingston. Rapidly going on, bladder removal is a radical cystectomy, and we take out the entire bladder. We take out the lymph nodes as well to see if they have cancer in them at the same time, and part or all of the urethra. It is different indications, but as I mentioned, generally it's most common when it's invaded the wall of the bladder. Certain patients with recurrent tumors that do not respond to BCG or their treatments, we do finish by doing radical cystectomy, but it's a major procedure. It's a bit different, obviously, in men and women with the anatomy. In men, we tend to remove the prostate and the seminal vesicles at the same time for various reasons, including that you have better margins on taking out the cancer. Women, again, it depends on the exact situation, but it's not uncommon that these other organs beside it will be removed to ensure that we remove everything without leaving any cancer behind. And that's sort of tailored to the patient, of course. Removing part of the bladder is a question we get sometimes. It's actually very uncommon that we do it for the reason that if a cancer starts in one side of the bladder, it could recur in the other side of the bladder. And so removing part of it is generally not indicated, but it can be an option in certain circumstances. What do we do when the bladder is gone? Well, there are different ways of replacing our bladder. The theme in all these 3 options is that we use a piece of intestine to connect the urinary system to that. And the ileoconduit, the stoma, we call it, drains into a bag on the outside with an appliance bag, and the urine drains continually there, and you empty the bag. It's the simplest option. There's a lower complication rate because it's a simpler surgery, but there's certainly complications we'll get into as well. An orthotopic neobladder, sometimes called a Studer after the inventor from Switzerland, is us fabricating a new bladder, or look-alike bladder, if you will, with intestine. And it's not a bladder, but it does work to contain the urine, and we can attach it in a way that there is no sac on the outside and that you more or less urinate normally, but it's certainly more complicated. There's some risks with it. In Indiana pouch is the least used of these options. Instead of using small intestine, we use large intestine. And instead of having something that drains continuously, there's what we call catheterizable stoma, where we can pass a catheter through directly into the conduit and drain it from time to time. So what happens after radical cystectomy or bladder removal? Well, it's a major surgery. Most patients are in the hospital for a week or so. Few leave at 5 days, and it's not uncommon some are at 10 days or longer. And then we advance your diet. You have to recover from reattaching and detaching the bowels, taking out the bladder. It's a long surgery that typically takes 5 to 6 hours. And there's a lot of lines and catheters and drains that are in place after the surgery. There is definitely problems which can follow this surgery. It's a major surgery, and it certainly has a high risk of having some complications. The goal is to keep it to minimal, but there's certainly a high risk of complications after this surgery. These are some of the problems. I won't get into all of them, but there's a recovery to be had, and you need a team, you need a support to get through this. But it can be, many people have gone through it, and the results can be very good. But these are some of the problems. I won't go through all of them for the sake of time to take more of your questions. But radiation therapy. So do we have an option not to remove the bladder? And the answer is yes. Radiation therapy is used for different cancers. The idea is that you target electrons to the cancer. The result of having that high energy in the region of the cancer is that it kills the cancer cells. And it's not something that happens overnight, however. The accumulation of the mutations that it induces and the problems that it causes accumulate over time, and it kills the cancer, but it can certainly also affect um, bystanders in the same area. And so we use it in bladder cancer for palliation or treatment of bone pain that are related to metastases. It's quite effective. We also use it for trimodal therapy, which is a way of preserving the bladder, where we radiate the bladder, we give chemotherapy, and we scrape out all the cancer beforehand with the 2-RBT. And in some case, and I'll get into that in the next slide. In some cases, we also will treat the bladder to try and stop bleeding, which is continuing from a tumor which we can't remove. And it's not recommended for all patients for sure. So TMT, or trimodal therapy, as I mentioned, has 3 components: radiation therapy, chemotherapy, and a complete transurethral surgery. Which patients should consider this? Not all patients. You need to discuss with your team. You need to have good bladder function. If the bladder is not useful to preserve and that it's causing a lot of problems already, then trying to preserve it doesn't make much sense. Obviously, the number of tumors, pathologic features, they don't all respond to chemotherapy in the same way. Patients who have a blockage already of their kidneys due to the bladder problems don't do well with radiation. In a similar way, if you can't tolerate the chemotherapy, the radiation is going to be less effective. And so there's a follow-up that's quite strict after this, because in the end, 25% of patients end up having a surgery because the radiation is not effective enough. And so, and you can't do a neobladder or a Studer after, because of the fact that everything's irradiated, the things don't heal as well. And so it has some nuances which are important to understand with your provider. So switching gears a bit to advanced bladder cancer. This is spread outside of the bladder, whether it's in the lymph nodes, whether it's elsewhere. Those are the 3 treatments categories that we'll go through: chemotherapy, immunotherapy, and targeted therapy. So chemotherapy, rapidly dividing cells. Chemotherapy in general targets rapidly dividing cells, and in the process kills them. And usually it's given intravenously, but it can also be administered directly. And in bladder cancer, for non-muscle invasive disease, we will put chemotherapy directly in the bladder. The advantage of this is that you don't get all the side effects from the systemic or the intravenous injection, because it just stays in the bladder, then we drain it out after. So there's minimal absorption to your body, but the surface of the bladder is highly exposed to the chemotherapy, and thus the potential for cancer cells being there receive a high dose of chemotherapy, which prevents them from coming back. And so there's different drugs that we use, metamycin C and gemcitabine, the most common. Intravenous chemotherapy is, as we alluded to, used in many cancers, including bladder cancer, and this is given in the circulation in the bloodstream, and it targets cancer cells wherever the blood travels to. And those are some of the ones on the bottom. So there's 2 concepts in chemotherapy that we use: neoadjuvant and adjuvant. These are medical jargon for saying before the main treatment and after the main treatment. And the main treatment often is surgery. There's good evidence that giving chemotherapy before surgery for bladder removal is helpful to improve survival outcomes. Giving it after can also be appropriate in certain circumstances for chemotherapy, but more and more it's evolving to involve immunotherapy, and that's to target microscopic cells that may not have been removed. The side effects think most of you have known someone or have heard of someone who's had chemotherapy, and these are the side effects: fatigue, nausea, vomiting, diarrhea, hair loss, and so on. They're not treatments that are particularly easy to go through. Immunotherapy is relatively new, not entirely in the sense that if you're listening, BCG was invented 50 years ago, but there's something called immune checkpoint inhibitors. This is a protein called PD-1, PD-L1, and it's essentially the immune system breaks. So the cancer tricks our own immune system into thinking that no, we shouldn't keep attacking the cancer. And these drugs take off those brakes that the cancer, as it were, applies to the immune system. And they're quite widely used now. They stimulate what we call T cells in the circulation in the tumor area to continue attacking the cancer, and it works. And not in every cancer in every situation, but in many, and bladder cancer, fortunately, is one of them where it works quite well. And so there's a lot of research that's going on, a lot of clinical trials testing these agents. Immunotherapy in bladder cancer was first approved as second-line therapy. There's trials just a couple of days ago using it before surgery and after surgery. There's now used in advanced bladder cancer as first-line therapy with another medication. It's evolving, and so I can't really go into all that. I'll leave it to that. Immunotherapy, because it stimulates your immune system, and your immune system is everywhere, in its essence, the side effects can be anywhere. And this is inflammation happening in places where it shouldn't. And this can be, it's usually quite rare. On the whole, immunotherapy is very well tolerated, but there is rare and sometimes very serious side effects. If you have inflammation in your brain or in your colon, you can have some pretty serious problems at times. And these are some of the potential side effects. Targeted therapy is our third class. And this refers to something which has a molecular or cellular target, which is particular to the tumor, and which, when we block that particular pathway in the tumor, it can kill the tumor cancer cells. Instead of just targeting blanket, rapidly dividing cancer cells, there's something particular that scientists have figured out to target. And these are often oral drugs, but can be by injection. And these are used in bladder cancer. One example is the FGFR inhibitor erdafitinib. So FGFR is a mutation that occurs in 15–20% of bladder cancer patients, and it causes certain cellular molecular differences which can be targeted by this drug so that these cancer cells are preferentially killed. And this is used as mostly in third or fourth line treatments for advanced bladder cancer in combination with other treatments as well. And this is evolving with clinical trials. A newer one is called enfortumab vedotin, and this is a monoclonal antibody. And so this is an antibody is something which attacks the target, which is the tumor cell, and in particular the nectin-4 on the tumor cell. And the scientists have engineered these antibodies to, when they come and find the tumor, to bring along with them in the back, as it were, a chemotherapy, which, because it's close to the tumor cell, more or less gets dumped on the tumor cell and in the process kills it. And this has been actually quite effective. It's given in combination with the immune checkpoint inhibitor pembrolizumab, and is used now as first-line therapy where it's available for patients with advanced or metastatic bladder cancer. So changing gears again a bit to clinical trials, this is how these new drugs have come to be, is that they've been tested in patients. There's always a process. We don't start with patients. We start with models. We start with laboratory experiments. And then there's initial trials in patients to see if it's tolerable, and then advances to the phase, what we call phase 3 studies, where we're comparing this to our current treatments and seeing if it's better. And fortunately, for patients, we've had many advances in bladder cancer, and these are to improve the therapies and bring our new innovative ideas to aid and help patients have better outcomes. And so, whether it's new treatment options or reducing side effects, we do this through clinical trials. And so clinical trial participation, in the end, can be very helpful to society, to the next person who has bladder cancer, but it's voluntary. There's no obligation to participate in clinical trials, and they vary. There's different follow-ups, and it's not everyone that's allowed in every trial. And so there's a whole bunch of rules that go along with this, but it certainly can be helpful to advance things and bring new treatments forward. So how do you find a clinical trial? Well, the general portal is your current doctor. Certainly, large academic centers tend to have more trials available in general. There's trial databases where patients can go and see what trials are available in different places, and ask your doctor as well, because this can be certainly an interesting option depending on the situation. So finishing up with therapies under development. This is not exhaustive, just a few ideas to follow the idea of clinical trials, because there are clinical trials in all of these agents. TAR 200, again, at the big European conference 2 days ago, was shown to be efficacious in patients who don't respond to BCG. Now, this is not efficacious like we can give it in the clinic tomorrow, but like they're headed to larger phase 3 studies. And this is an innovative idea. There's a device, more or less a pretzel, at least it looks like one, which the chemotherapy is put inside. We put this device right inside the bladder, and as a result, it can sit there for a couple of weeks without causing any real problems, it seems. And it diffuses the chemotherapy to the bladder, and it appears to be effective to date. Further trials to confirm it. They've tried this with erdafitinib, the other medication I mentioned, and there are different trials ongoing. Another approach is making chemotherapy incorporated into a gel. And this is a trial that was done in the US a couple years ago, with other similar trials ongoing, where the urologist will put the gel right into the bladder or right into the renal pelvis, often for upper tract cancers, and see if the presence of this gel over time diffuses the drug, and it seems to work to reduce cancer recurrences. A very different idea is putting a virus. Now, viruses all around us, but certain scientists have been able to engineer viruses such that they kill tumors. And this is a trial is ongoing to see if it works, but where they give this virus, and I have no relationship with this company, but they give this virus into the bladder and see if it can kill the bladder cancer cells. And there's various similar therapies under evaluation elsewhere. Just one example. This is a trial that I'm involved with, where we have certain data from the clinic and from the lab suggesting that anti-androgens actually can prevent recurrences of non-muscle invasive bladder cancer. And this is a molecular target, as it were, but it's actually used in prostate cancer for other reasons. But it appears that it may be helpful in bladder cancer, and we're doing a trial where we randomize patients who are recommended to have BCG, to male patients with anti-androgen bicalutamide for 90 days, or the standard of care BCG. So both arms get BCG, but one of them by chance gets the bicalutamide as well. And so that's with the support of those two entities at the bottom, CIHR and the Cancer Research Society. So we've covered a lot, and I hope this has been helpful to understand a bit of different aspects of bladder cancer. Bladder cancer is treatable when it's detected early. I think that's a take-home message. Blood in the urine is not normal, and it should be investigated. The treatment and the prognosis is, I mean, it's complicated. There's a lot of nuances to be known, but by and large, it depends on the grade and the stage of the cancer. Things are very different with a non-muscle invasive bladder cancer than they are with a muscle invasive bladder cancer. 3/4 are non-muscle invasive, but 1/4 are muscle invasive at presentation, and this is more significant. It's more advanced and has higher risk of causing problems. Advanced bladder cancer, metastatic disease, is another entity as well, where there's a lot of systemic treatments we went through briefly, and more emerging. And so there's progress being made. We certainly appreciate all the patients who do participate in clinical trials, because this permits us to go further and advance our care. And it has to be done in the proper way, of course. So with that overview, I'll hand it over to Teresa, and if anyone has any questions, I'd be happy to try and take a stab at it.
Great. Thank you so much, Dr. Toren. What a great overview of the disease, and some exciting insights into the latest treatment options. So as Dr. Toren said, we'll open the floor to questions now, so you can type them into the chat box and I will read any out. First question, why does bladder cancer have such a high recurrence rate?
It's a good question. It is somewhat unique in that sense that few cancers can be completely removed and then still come back. And they come back sometimes 3 years, year, 5 years down the road. The main reason that that probably happens is the reason that it happens in the first place. Accumulated problems, genetic problems in the cells of the urothelial are abnormal or predisposed to become abnormal, and as a result, they develop into cancers. But the ones that didn't develop into cancer were often exposed to the same abnormalities, the same exposures, whether it's smoking or other things that cause them to be predisposed, even if you take it the first. So in a sense, it's a we call it a field change where the entire urothelial cells have a tendency to become cancerous. Obviously, one presents first, usually. Sometimes patients present with multiple cancers at once. It's not uncommon. And so it's to do with the reason that it develops in the first place, but it is somewhat unique because um, fortunately for many non-invasive bladder cancer patients, we can follow you for years and remove them when they come, and some of them are not that serious. And so it's unique, but it is thankfully not always a bad thing.
So some questions in the chat. If you have non-muscle invasive bladder cancer and it's returned every 6 months for 18 months, with 8 new spots, does that make you at higher risk to develop muscle invasive bladder cancer?
Well, there's a lot of that's a loaded question a bit. In general, um, there are different clinical tendencies. Patients with high-grade disease have a much higher risk, in fact, of developing muscle invasive bladder cancer. If all you have is low-grade disease, it's really very few of those patients that end up with muscle invasive disease. It does happen, but it's unusual and uncommon. Certainly having multiple recurrences, it can be an indicator of the biology. For some patients, multiple recurrences arrive with only a low-grade disease. For other patients, it turns into a higher grade disease with time. And so there is a lot of different scenarios. Having multiple recurrences in and of itself, if you look at statistically, is a risk factor for having a muscle invasive disease, but not necessarily, because it's often a question of biology. And so, um, but there's no standard answer to that in a sense. I hope that helps.
Yeah. And would doing immunotherapy help to increase the survival rate?
So immunotherapy has side effects. It is very well tolerated. It is very expensive as well. So it has to be proven that it's effective. And the studies that have been done are in certain clinical scenarios, mostly patients with advanced disease, because we need better treatments for these patients. There have been studies in patients with localized disease, and it does work, but not it's not really worth it. And if I could say it like that, in the sense that like you can spend $130,000 a year and get slightly fewer recurrences. Your value is quite low with the potential for, albeit rare, severe side effects. And so in Canada, for example, although there have been some positive trials, it's never used in localized disease for various reasons. Um, so it works, but you need to justify in a good clinical trial where it works best and where it also where it's has some value to be used.
Yeah. Okay. And can bladder cancer be linked to a previous cancer?
If the question is, can it be linked to cancers other than bladder cancer? The answer is, in some cases, yes. There are certain genetic syndromes where people have bladder cancer and something else. By and large, these are quite rare. Most patients that I've seen who have multiple cancers, there is no known cause reason why they have a kidney cancer and a bladder cancer, for instance, or why they have a prostate cancer and a bladder cancer. So in majority, no, but there are certain exceptions. But those are less common, and they tend to happen in younger patients in general as well. But so not necessarily, but it's possible.
A patient who is not responding to BCG, so scheduled for radical cystectomy, is there any follow-up treatments that are recommended for that situation?
So we didn't go into too much follow-up after radical cystectomy, but there is follow-up after radical cystectomy to to detect recurrences which can arise. Usually your doctor will follow you with scans, like a CT scan at certain intervals. If they did not take out the urethra, um, typically they'll do some washings of that at some point to make sure there's no cancer cells in the remaining urethra, or at least look at it on the scan or sometimes with a camera. There's different ways of doing that. And so there is a follow-up, and that depends, of course, on your pathology. If there's cancer in the lymph nodes, then certainly the risk of it coming back is higher and the scans will be a bit more frequent. But if you had BCG unresponsive non-muscle invasive disease, which ultimately required a cystectomy and then it was taken out, your risk of recurrence is not necessarily the same. And so these follow-up schedules are adjusted according to your risk. But absolutely, there's follow-up, whether your bladder is in or whether it's out, there's follow-up after.
Okay. Is it common to have abdominal discomfort with recurring low-grade non-muscle invasive bladder cancer?
Most patients that I've seen with bladder cancer do not feel it. Patients who have pain in their pelvis, it's more likely to be, if it's related to the bladder cancer, it can certainly be other things. There's other things down there. But if it's related to bladder cancer, superficial bladder cancers in and of themselves don't really cause pain from my observations. Um, there's certainly other things. The intestinal pain and bloating can be unrelated to bladder cancer as well. In general, non-muscle invasive bladder cancer, problems with urination, sometimes urinary symptoms. Pain is certainly less common for a low-grade TA disease.
And then is BCG plus a virus a better option?
Well, that's probably a question I know there are some clinical trials trying to address that question. I mean, I mentioned my clinical trial, we're trying bicalutamide to see if that improves the outcomes. I believe there are some clinical trials that are looking at viral therapy in combination with it. I'm not that up to date on whether those are in phase 1 or phase 2, or I've not seen the results that I can remember offhand. But the answer to that is we'll have to see the results of the clinical trial. I guess that's the short of it. And that's where, if I can put a pitch as someone who does the clinical trials, having patients participate helps us answer the question. But of course, it's all voluntary to do so.
Okay. And a pretty specific question, but age 43, female. She has a rare form of UTUC metastatic. She had a radical nephrectomy and upper left lobe of the lung removed. No sign of cancer at the moment. Needs to choose between chemo and immunotherapy as part of after surgery treatment. Is that common to do both at the same time, or should you only do one type of treatment at a time?
Well, what you're describing is not something that we see commonly. For cases that are more difficult and more rare, it's somewhat a blanket answer, but it's always a good discussion with different colleagues who we have multidisciplinary rounds, it's called in some centers, or clinic tumor board rounds. And this is a discussion of not just the urologist, but the pathologist, the medical oncologist, the radiation oncologist. We get together usually every week or so, and we discuss cases that are more difficult to have a sort of consensus to see things from different points of view. And I think a case like that, certainly you need a multidisciplinary discussion because it's complicated. It's not necessarily typical. And if there's a genetic reason known, then that may have an impact on how things are approached. The development of immunotherapy is changing. It was used only in second line a few years ago, but now it's used right after radical cystectomy in some centers with the good evidence, and soon to be given before radical cystectomy. The results 3 days ago suggest that giving it with chemotherapy before and after radical cystectomy may be helpful. Of course, unfortunately, there's always a delay. Because as I mentioned, these are not cheap drugs, so it takes some time to get everybody to say, yes, we're going to pay for this. So it may not be a straight answer, but I think that's something that you need to look at all the details and weigh the pros and cons. And also as a patient, I would add, it's important that you understand the pros and cons because immunotherapy and chemotherapy, for instance, are not the same treatment. They're very different side effect profile. And depending on your medical situation, one may be preferable to the other as well.
Okay, great. Just a few more questions. How often does non-muscle invasive bladder cancer go to the ureters or kidneys?
That's a good question. In general, the risk, it does depend on the grade of the cancer and the stage. It also depends, certainly patients who have more recurrences, it can happen. Overall, the risk for low-grade bladder cancer is low. It's certainly, if it's just a we call a TA, a low-grade disease, the risk is actually less than 5%. It's perhaps around 2%. And recent guidelines for patients who are low risk, it's not even clear that doing imaging of these kidneys is actually necessary because it's so low. Diseases like carcinoma in situ have probably a higher risk. But again, all told, these risks are not very high, but it depends on the context. It also depends on the personal risk factors. Patients who are smokers have a much higher risk. It's clear. And so a lot of us will have a lower threshold to do imaging of the kidneys in someone who's been smoking for 40 years than someone who hasn't. And the age goes with that as well in terms of exposures. So different factors need to be considered, but their risk is present. In all patients who have a diagnosis of bladder cancer, we will do imaging of the kidneys at the outset to see if there's something there as well, because sometimes you can have a tumor that starts in the kidney and then through the course of passing through the waterworks, disseminates or spreads into the bladder. And so if we see a tumor in the bladder, we like to know if it came from the first part up in the kidneys or not. And so that will be done in patients who have a new diagnosis with bladder cancer and at intervals as well, depending exactly on the clinical situation.
Okay. And this is a question that we are working on, but I'm curious to hear your input. Why does bladder cancer have such a low public profile? Something
That
that
is,
we're working on all the
you
time.
know, that's a good question. I mean, some cancers, um, well, they affect different demographics, I think, for one. So some cancers, like breast cancers, affect women of all ages, and it's very common as well. And so prostate and bladder cancer, prostate and breast cancer are very, very common. So there's more people. Bladder cancer is nonetheless common. Um, Certainly, the patients who get bladder cancer are older. We do have younger patients, unfortunately, a bit more and more. But by and large, these are older patients that we follow. The average age of diagnosis is 73. So, the media story is a little bit different than someone who's diagnosed with muscle and triple negative breast cancer at 39. And so there's definitely some media that I think Bladder Cancer Canada is working on this. Awareness is an issue. It's true that a lot of the patients, well, smoking is a risk factor. So more smokers are bladder cancer patients per proportion of the society, but many patients are never smoked and still get bladder cancer. But um, there's a certain predisposition of smokers to get bladder cancer for sure. So it needs to be worked on. I think the work of Bladder Cancer Canada and patient advocates, it's really, as a researcher, more and more important to have, and we are blessed to have a few on our team, but patient advocates who step up and say, this is important, let's do something about it. At the end, it makes a difference. I worked in prostate cancer as well, and there's a lot of patient advocates in prostate cancer. Now, prostate cancer tends to affect people who are 65, who just reach retirement and have a bit more time. Bladder cancer is maybe 8 or 10 years down the road on average. But the people who really take it to heart and move it along is often what makes the difference. And so encourage, if some of you have that sort of inclination, to get involved and take it somewhere, because there's certainly a lot more work to be done. We're fortunate to have a lot more new treatments coming, but it also takes advocates. Governments don't just listen to doctors, they listen to patients. And having advocates who say, this is something valuable, we can do something for it, makes a difference. And so I encourage you, if that's your inclination.
Yeah, that's great. Thank you. Okay, and last question. What would be the time frame when BCG would be considered a fail? And then what would be the option for treatment if it is considered a fail?
So there are different, I'm not going to get into them here, but there are different definitions of BCG failure. Is it something that doesn't respond to BCG? Is it something that's recurred despite BCG? And then BCG failure encompasses two of the three definitions. But briefly, it's having a tumor that is high grade after BCG, or having something that comes back in a significant way rapidly. Um, and so that depends on the pathology, the grading and the staging of the next surgery. And so, and sometimes the urinary cytology as well can be helpful. And so that there is another option, which I didn't mention, for BCG failure, which is a combination of two chemotherapy drugs, gemcitabine and docetaxel. This is again in clinical studies, but the retrospective studies are very convincing, and it is in use across Canada at most major academic centers, for people who fail BCG as an alternative to going to radical cystectomy, which is not always a feasible option. And so patients who recur with high-grade disease in 6 months after BCG therapy are considered failures.
Okay, great. Well, thank you so much. I think we will leave it there. So we hope everyone enjoyed this session. Our next session is a deep dive into the different urinary diversions on October 8th. And we're also hosting an in-person education event in Winnipeg on October 22nd. So in the chat, Mary Lou will share a link to register for either of these sessions, as well as a link for a feedback survey for tonight's session. If you need any accommodations to complete the survey, or you have any additional comments or questions, please reach out to us at 1-866-674-8889 or email info@bladdercancercanada.org. And a recording of this session will be uploaded to our website in the coming weeks. Canada Walks for Bladder Cancer happens this weekend in communities across Canada, so we hope you can join us, or you can step out anytime, anywhere during the month of September to help raise funds for bladder cancer research support programs and help raise more awareness. So visit bccwalk.ca for more information. Thank you again, Dr. Toren, for sharing this vital information about bladder cancer with our community. We're truly grateful. And thank you for everyone who attended. I hope you have a great night.